Our next speaker is Dr. Deidra Cruz. She is a nephrologist and epidemiologist. She is an associate professor of medicine in the Division of Nephrology at Johns Hopkins University School of Medicine and is associate vice chair of diversity and inclusion in the Department of Medicine. Her core area of research addresses disparities in the care and outcomes of chronic kidney disease. She has examined the contribution of social determinants of health, including poverty and access to healthful foods, to disparities in kidney disease. Dr. Cruz shares her insight this morning in Unequal, the story of chronic kidney disease. Please welcome Dr. Cruz.
So good morning, everyone. I'm really excited to be here, and I want to thank Dr. Jerkovitz for inviting me. It wasn't a very long drive, so it was actually quite nice coming up this morning. So as you see my title, I'm sure, and we've kind of already set the stage. Should I use this or this? Oh. In case I want to walk. Okay. So we've kind of already set the stage for thinking a bit about disparities in kidney disease, which is going to kind of be the topic of our time together, hopefully over the next 30 or 35 minutes or so. And what I'd like to do with you is to kind of begin our time together in a similar way that I'll end, and that's to say that disparities in kidney disease are pervasive, but they may be surmountable. And so before we get into the objectives of our time together, I wanted to mention what was said earlier, that is that I do some consulting for the MITRE Corporation, but there is no relationship between that work and what I'll be covering today with you. And so our objectives are going to be to first sort of describe what's meant by disparities. I think it's important to make sure that we're all talking about the same thing when we think about disparities. And then we'll go into some of the key disparities in chronic kidney disease. Then we'll look into thinking about some of the potential root causes of these disparities. And then next we'll talk some about how these disparities might actually be able to be reduced or mitigated. And then finally we'll think a bit about what clinicians and health systems might do to address disparities in chronic kidney disease. We won't cover this very much, but I hope it will sort of spawn the discussions that we'll continue to have over the course of the day today. So first, again, I make no assumptions about whether some of you in the room may be experts on this topic, but I want to make sure we're all talking about the same thing when we speak of disparities. So a disparity is defined as a difference or a lack of equality. When we speak about health disparities, these are population-specific differences in the presence of disease, health outcomes, or access to health care. Now, the Institute of Medicine put forward a report some years ago that stated that health care should be safe, effective, patient-centered, timely, and efficient, and that above all these things, health care should be equitable, meaning that care should be provided that does not vary in quality because of personal characteristics such as gender, ethnicity, the geographic location of where a patient lives, or socioeconomic status, so things like income or educational level. And then if we don't have these things, what we have are health disparities. And so when we think about disadvantaged populations in terms of how they relate to health and healthcare disparities, these are going to be groups that are adversely affected individuals who have systematically experienced greater obstacles to health that are based on a number of different potential factors, like the ones that are listed here, including racial or ethnic group, religion, socioeconomic status, gender, mental health status, sexual orientation, geographic location, or any other characteristics that historically have been linked to discrimination or exclusion. And so in chronic kidney disease, there are a number of disadvantaged populations. Now, during our time this morning, we'll focus on racial and ethnic groups, and we'll also focus on SES, which is socioeconomic status. But there are a number of disparities or disadvantaged populations in chronic kidney disease that have been documented in the literature, including around gender, and I'll just note a few of them. So overweight or obese women are actually less likely to receive transplants than men. And so when Dr. Swanson was speaking about that men they're overrepresented in the transplant population, it's in part due to the fact that men are indeed overrepresented in the ESRD population, but there also appears to be some disparities in that access and receipt of transplantation is greater for men. With regard to mental health, major depressive symptoms have been associated with increased risk of developing end-stage renal disease among people with diabetes. And then regarding geographic location, people who live in more remote areas, like rural areas, are less likely to receive specialist care, such as seeing a nephrologist. They're also less likely to undergo some of the laboratory testing we talked about earlier, like the urine albumin testing. And they're less likely to receive some of the medications that are recommended for chronic kidney disease patients, such as the certain blood pressure medicines like the ACE inhibitors or angiotensin receptor blockers. And these individuals living in remote areas are also more likely to die than those who live closer to a nephrologist. And so earlier this morning, the social determinants of health were mentioned. And just conceptually, what we think about when we're thinking about the social determinants of health is that kind of at the bottom there, we have these sort of downstream effects. We have we take, just as an individual, we're going to be of a certain age. We're going to be either male or female. We're going to have other constitutional factors like our genetic background that kind of make up these individual aspects. And then upstream from that, we have lifestyle factors, what we eat, whether we exercise, that play a role in our health. Upstream from that, we have our social and community networks that play a role. And then further upstream, we have our living and working conditions. So whether we work in an environment where we're getting some toxic exposures, or whether we have clean water, whether we have access to healthcare services, and whether we have adequate housing. And so these are considered the social determinants of health. And so thinking about that, let's turn to some. I just want to highlight a few of the disparities that have been documented across the spectrum of chronic kidney disease. And what I'll start with are disparities in pre-end-stage renal disease, chronic kidney disease. So Dr. Shahinian kind of spoke to you about how we characterize end-stage renal disease, and then the earlier disease we often will think about as CKD. So it's been said today, we've spoken a lot today about diabetes and hypertension, and it was mentioned that probably many of you know that rates of diabetes and hypertension are certainly higher among several racial and ethnic groups in the United States. That's not, everyone sort of knew that, right? And so given that, one might think that then that might explain the higher rates of kidney disease that we see, right? Would that make sense? That we see among racial and ethnic minorities, right? So this study was one of the earliest studies to really kind of debunk that notion. And what it essentially is showing, and I apologize so I am an epidemiologist, so I will be showing a lot of kind of data-heavy type of slides. So for those of you that are less familiar with this type of thing, I will try to make sure I explain the slides. But in this figure, this is national data in the U.S. And what they did was they divided up the population. They were looking at blacks, Mexican Americans, and they looked at those participants in the study who either didn't have diabetes or either did have diabetes or did not have diabetes. And the big message is that the rates of albuminuria, so this is this protein in the urine, the rates were actually higher for blacks than they were for whites, and they were higher for Mexican Americans than they were for whites, regardless of whether those individuals had diabetes or not. Okay, so it's not this disparity in rates of albuminuria is not explained by the greater rate of diabetes among these populations. That's sort of the key message. And so one of the things that I've been very interested in my work is in looking at poverty as well as looking at income level and seeing how it relates to the presence of kidney disease or risk of kidney disease. So here again, we're looking at albuminuria, again, this protein loss in the urine. And we were looking across income level. And this was in a study, a very large population-based study called the REGARD study. And so hopefully what you can appreciate is we're looking at people at the lowest level of income of less than $20,000 a year for the whole household, up to more than $75,000 per year. And you can see that there's this gradient where the people who earn the least had the highest rates of having this marker of chronic kidney disease. What I hope you can see this gradient sort of going down. What I hope you can appreciate is that gradient is steeper for the Black participants in the study, right? And so much so that when we went on to kind of account for other factors, diabetes, rates of hypertension, age, gender, and so forth, we found that there was a stronger association between level of income and this marker of kidney disease among the Black participants than there were among the white participants. Now, I give this sort of talk in a lot of audiences, and people say, oh, are you saying that income doesn't matter for whites? That is not at all what I'm saying. I'm saying that it seems, and I'll show several examples of this, that income level and other metrics of socioeconomic status seem to play a greater role in risk of kidney disease among minority populations than it does among whites. So as another example, we did a similar study in Baltimore, where I'm based, again looking at higher versus lower socioeconomic status, and again found the stronger association between low socioeconomic status and kidney disease among the Black participants. Okay, so this was somewhat shown, a similar slide was shown earlier, but the basic message is that when we look at earlier stages of kidney disease, so stages 1 to 4 here, with stage 5 and beyond being typically where we're going to begin to classify someone as having end-stage renal disease. So what you can see is that these bars, we're looking at non-Hispanic whites, non-Hispanic Blacks, and then Mexican Americans, and then everyone together. I want you to focus on these first 2 bars and note that they're the same height, right? And so in general, and this has been documented time and time again, when we look at earlier stage chronic kidney disease, the rates are actually pretty similar between non-Hispanic Blacks or African Americans, whichever term you use, as compared to whites. So the rates are pretty similar. But when we begin to think about progression of that disease, it's that the progression of kidney disease or decline in kidney function is faster among racial and ethnic minorities than it is among whites. And so this study, this is from the multi-ethnic study of atherosclerosis. What they were looking at is they looked at participants in the study who began with a glomerular filtration rate that was greater than 90, which is very much normal, or those who began with a GFR that was between 60 and 90, and they looked over time. They followed these participants. I think it was 5 years of follow-up here, and they were looking at, who was losing kidney function faster. And essentially, what they found was that Blacks and Hispanics lost their function faster, even at this stage of pretty good kidney level of kidney function. And when we looked at the group that already had, sort of slightly reduced function, although still in what we would consider normal, that again, Blacks and Hispanics had a faster rate of progression. So what we're dealing with is more of an issue of progression of disease. So I want to summarize these pre-ESRD disparities that I've covered to say that independent of diabetes and other clinical risk factors, racial and ethnic minorities and individuals with lower socioeconomic status have greater risk of albuminuria, so that's the protein in the urine, and also a greater risk of progressive kidney function decline. And socioeconomic factors may underlie these racial disparities.